Ben.
Great, thanks very much. And again, thank you, Baroness Young, for your detailed review of the changes that are happening in the UK. And also thank you to the Change Foundation for organizing, I think, what's a great debate. And I, like many of you out there, have been avid UK watchers over the years, and any of you have heard me speak, I often talk about, I love to talk about great examples of things that are happening elsewhere, and that often includes great examples of admiration of improvements that are happening, particularly in primary care, as Ross had mentioned, and with after having read the background paper and listened to Baroness Young's remarks, I think I still very much want to be an NHS watcher. I think I need to step back for a moment and wait and see how this is all going to unfold. I think when I look at this, and I look at this from a couple of perspectives, and primarily my perspective is how would these principles fly in Ontario, and how are they related to some of the tough questions that we have to address? And from that, I guess, raises all kinds of really difficult questions that I really can't understand how would this possibly work if this were in Ontario, and I think by implication it would be very interesting to see how this would work in Ontario. Certainly, I think one of the biggest debates that we have in Canada is the whole question of regionalization. We've had 9 of the 10 provinces moved towards regional health authorities over the past 10, 15 years, with the exception of Ontario, and then the move in Ontario to, I think, what's admittedly a very the weakest form of regionalization in the country, and then the surprise with Alberta moving in the other direction. And often, in the context of that, I often talk, look, there's this regionalization in the UK, and look at the things that have happened, and now to see that model, kind of disappearing with this, I think certainly raises a lot of questions. I mean, certainly my own personal experience working in Saskatchewan is regionalization was not perfect by any means, but having 14 CEOs who represented different regions of the province in the same room at the same time was a great way to get a quick consensus on some critical provincial priorities or provincial directions that needed to happen, and then to have the coordination of that flow through that. It certainly made that a whole lot more complicated, and certainly seems much less complicated than thinking about how could you do that with 500 different primary care commissioning bodies. The other thing more fundamentally about the whole process of commissioning and the undercurrent of competition behind this is that there are certain instances where I can think very rationally, this makes a lot of sense, and others where I'm not quite sure. So maybe one distinguishing point is, can you think of certain services where it's provided by a single entity, and there's a marketplace where there's multiple different providers available who can offer that particular service? And some things that come to mind, like things like cataract surgery or a colonoscopy or a particular diagnostic test. There might be multiple people that could provide that. And in that kind of a context, the idea of commissioning makes intuitively makes sense that, GP groups can say, what, all right, all you guys, who can give me the best price here, and who can do this with the best measurable quality results? And I think I'm going to give, this contract to that particular group. That makes a lot of sense in terms of driving up quality and driving down costs. What I have a real struggle with is how that structure works in certain situations where integration, coordination, rationalization of services is what needs to be done. And I think, having, again, traveling across the country, both in administrative roles as a clinician roles, I can, some of the real challenging regional, issues that I've seen are examples like there's 3 different places that produce the same kind of services at relative low volumes, and every organization wants to hang on to their particular volumes, for a variety of different issues. Particularly, the providers are very attached to doing it that particular way. or coordinating call schedules across multiple communities, so that there's no gaps in call coverage, or you don't have situations where different you have 1 and 2 or 1 and 1 physicians in different communities. Examples where you're actually coordinating and creating some standardization across primary care. If you allow me one example from Saskatchewan, one of the things we did was map out the different pathways for the workup for certain types of cancer. And for one cancer, we found 57 different ways in which that could have been worked up by different clinical groups. And there's all kinds of reasons why those regional quirks or local quirks exist, and it's often related to deeply embedded local interests or local provider groups that want to do it a particular way. And it takes, what I've seen where you've gotten to a better place, requires an enormous amount of some kind of local leadership to try to pull those groups together and say, we got to compromise for the betterment of everybody. And that has typically been a really strong regional structure that had a very clear mandate to pull that off. How would you do that when you don't have that structure, but instead you have 500 different groups that are all negotiating these different contracts? And what happens if that local group has some degree of monopoly power? You don't have the same degree of choice. You've got a big power imbalance, and it makes it, my fear would that make it really difficult with that kind of a structure to make the tough decisions necessary in that type of a context. Other areas in terms of transferring this, I think there's been great progress in primary care reform. How would you get to a position where we're actually commissioning those different services? Here in Ontario, in our local context, we have family health teams. That's a great addition to Ontario, but we still have major struggles just to figure out internally what do our internal structures and work team, ways in which we work together as a team fit together, let alone how do we take on this task of contracting out more broadly. Really interesting comments about the whole idea of engaging the public, and that's something that I'd love to follow with great interest over the next few years. I think the major challenge is trying to identify who are the right members of the public to give that strong voice, and kind of look forward to hearing more about that in the future. The whole question about targets. I agree with Ross. I mean, targets were, I think, absolutely essential part of the success of the National Health Service. With the evolution of quality improvement plans, I mean, the embedding of targets and timeframes is going to be something that's now going to be legislatively enshrined. I'm not sure if, as I was reading the materials, if it was a matter of eliminating targets altogether, or eliminating process targets and then moving more towards outcome targets. I think it's more the focusing more on outcomes. Is that correct?
It is regarded as wrong because it's top down.
Yeah.
But the more important thing is to focus on outcomes. There will be some process outcomes as well as outcomes.
We got to have targets, and you can still have global provincial targets. They can be done in a way that are bottomed up and reflect what people are setting as their local targets. You can have some kind of process to reconcile those two, but we got to have targets. So if the UK is really moving away from that term, then I think that would be something that I'd be really concerned about. If we're only focusing on outcomes, again, I'd be quite concerned about that, because I think you got to have a balance between process measures and outcome measures. I think that's pretty fundamental in quality improvement. The outcomes are what resonates with the public and with patients. The process measures relate to providers, because this tells me exactly what I need to do. Too much of a focus on outcomes could lead to situations where we have more cherry picking, where people are going to, perhaps not selectively look at people who might be more inclined to be difficult to comply with, whatever advice or counsel we would give to the people that we're serving. The last point, which I think has already been mentioned, but I'll just reinforce it, the whole question of leadership. Again, one of my strongest reflections from my time in Saskatchewan was, we had great government support for the quality improvement agenda. I think a lot of great frontline buy-in. But the mantra, the popular political mantra at the time was, I want to go out to the electorate and tell everybody how much we're cutting, the administration out of the system. We're putting it all into direct clinical care. It was a great political sell, but it was one of the biggest barriers to driving system-wide improvement, because every time you wanted to work on patient experience or lean or flow or improved chronic disease management, it was always the same person from the same organization coming to the same meetings, and that person being incredibly stretched. So I'd ask questions, what kind of capacity do you need? When we talk about, 1 to 2% of our workforce having advanced skills and leaner Six Sigma, is that all going to be cut out? And if that's the case, could you please make sure that some of those resumes get sent over here to Ontario? Thank you.
Thank you, all three of our panelists.